All right, we'll briefly jump into vascular pathology, and we're going to start on the arterial side of the circulation. So we're within the arteries, just to keep yourself kind of anatomically located as we keep talking about the different disorders. So here are the list of vascular pathologies that we're going to go through in this unit. Obviously, I only have about 35 minutes left in the Friday lecture series, so we're only going to just get started on this topic. But let's start with peripheral vascular disease. As you can see in your notes, we start with peripheral vascular disease. And this is a pretty generic description in terms of where we are in the circulation. So peripheral vascular disease, as it says kind of lower in the slide, that could describe vascular disease on either the arterial or the venous side. So since we're going to start on the arterial side, we're actually talking about peripheral arterial disease, PAD. Peripheral arterial disease specifically tells you that we are in the artery. So this is just a good practice to start getting into if you're someone that has difficulty kind of being specific in all the words of a title. Some of you that have come to talk to me about the exam, it's hard to take the information that every single word is giving you. But the name of this disease is very descriptive, and it tells you exactly where you are and kind of what we're dealing with. So the nice thing about taking a pathophys class and getting to peripheral arterial disease is that you once again already have the pathophys down, because peripheral arterial disease is simply atherosclerosis in the periphery. So all of the steps that we learned in atherosclerosis, cardiovascular risk factors that damaged the endothelial cells, resulting in lipids and macrophages moving into the wall and forming adult plaque, is the exact pathophys of peripheral arterial disease. This is just when that plaque is forming in a peripheral vessel. So just like when we talked about coronary vascular disease, the progression of peripheral arterial disease involves a narrowing of the lumen of the artery. And this is, again, we're keeping the function of the circulation in the forefront of your mind. If the lumen is narrow, the job that the blood normally does will be limited downstream of that blockage. Specifically, the ability to deliver oxygen and nutrients to the downstream tissue will be limited when there is plaque narrowing the lumen. So then when we look at the symptoms of peripheral arterial disease, they make a lot more sense if we're always keeping the function of the blood delivery in mind. Now, as it says in your notes, the symptoms that they have will be dependent on where the blockage is. It's very common to develop peripheral arterial disease in the lower extremities, but wherever the blockage is where you'd have the symptoms. The primary symptom of peripheral arterial disease is something called intermittent claudication. Intermittent claudication is just a fancy way of saying pain with walking. So intermittent claudication simply means pain with walking. Typically, a patient has to have at least a 50% blockage before they'll start developing intermittent claudication symptoms. So much like we talked about with the heart, early atherosclerosis has no symptoms. It doesn't hurt when the lipids go in our wall. We don't feel it when the plaque is growing. All of the symptoms are a result of blood flow blockage. And by the time you have symptoms, you are already quite developed in terms of your plaque. Now, you can see in the cartoon picture here, the man is they're kind of illustrating that his calf is hurting and he's stopping and he's leaning on the fence and reaching for his calf because his calf is in pain. And intermittent claudication most often presents itself as calf pain because our calf muscle has the highest oxygen demand during walking. It has the highest oxygen consumption of any muscle group during walking. So if it has the highest oxygen consumption during walking, and the symptom is a result of inability to match supply and demand of oxygen to a muscle, then the calf muscle is most likely to experience a supply-demand mismatch because its demand is so high. So you could get ischemic pain in any skeletal muscle if you were really working it. Because of the use of the calf during walking, this is the primary symptom of peripheral arterial disease, most commonly reported. More signs and symptoms that you are having atherosclerosis in your peripheral arteries. The first is atrophic skin changes, and you can see a picture here. Atrophic skin is skin that becomes thin and mechanically weak. So you can see this individual has like a scab where there was a break in the skin. The look of thin atrophic skin is often kind of has a shiny appearance, a real kind of dry, shiny appearance. Atrophic skin is incredibly susceptible to breakdown. So this is something you want to be keenly aware, depending on positioning and mobility, to look at the skin and see how well it is kind of mechanically holding together. Blanching with elevation is a big sign of peripheral arterial disease. In a normal, healthy person, our heart pumps the blood into our peripheral circulation, and we can deliver blood through our whole body. If you put your feet up in the air, your heart can pump that blood up against gravity, and your feet continue to be perfused with blood. If there's a major blockage to an artery and you lift your leg up, against gravity, now the ability of the heart to push the blood up against gravity through a narrow lumen becomes compromised. So when you are up against gravity, we see reduced perfusion pressure in that extremity, and it looks actually white. Blanching with elevation is a whiteness in color, kind of giving evidence, visible evidence of poor blood flow to the limb. Then the opposite of that is what's called dependent rubor. Again, dependent means you're down into the dependent position with gravity. And this occurs after you elevate. So you elevate the limb and it blanches, and you leave it up for a minute or two. And when you sit down, the foot gets incredibly red. This is evidence of the ischemic signal that the tissue was giving when it was blanching. So when the foot was up in the air, that tissue was screaming for more oxygen, sending out all the local signals to the blood vessels to vasodilate as much as they can. So as soon as you put that foot down and now you have gravity helping you, blood kind of rushes into the foot. Cool to the touch would be a sign of reduced blood flow. It's very helpful to just put your hand on the foot to see how well they're perfusing their foot. And then a weak or absent pulse in a distal extremity can be a sign that there's poor perfusion, because, right, like dorsalis pedis seen here is downstream of the larger arterioles in the leg and can give evidence that there's poor perfusion. So as PTs, we deal with peripheral arterial disease a lot. We evaluate it, we treat it. So we can use how far they can walk as a measure of pathology. And by distance they're able to walk, I mean how far can they walk before the onset of pain? How far can they walk before the onset of pain? Their ability to walk can be compromised in terms of weakness and tiredness. So that can be their only symptom, that they're just not delivering enough oxygen to supply for walking. But we're typically looking and kind of measuring the pain or when the really new onset of weakness occurs. So if they can go 2 blocks or more, it is considered mild. 1 block is moderate if it's less than a block before they're having pain or a new onset of severe weakness, tiredness, that is considered severe. Now, just like in stable angina, which is kind of what we're experiencing in the leg, intermittent claudication is very much the same phenomenon as stable angina. When you have a known stimulus that increases the metabolism, increases the oxygen demand of a tissue, the vasculature can't keep up, and they have ischemic pain. If you stop the activity, if you rest, that pain should go away, because with rest, the tissue has decreased oxygen consumption. So as you decrease demand, the supply can now meet it, and the pain or the weakness would go away. Another test is the graded treadmill test. This is a really excellent assessment to show change over time, because it's a standardized test and you can document either progression of the disease or improvement. Now, there's some variability in the description of this test. Oops, I thought more was on here. But on your notes, you can see you set the walking speed to 2 miles per hour. And then you start the grade at 0%. Every 2 minutes, you increase the grade by 2%, meaning you're increasing the incline. And you wait and you document how long does it take before they have claudication symptoms. Now, sometimes the graded treadmill test is reported as the initial claudication symptom, how long until they have the very first feeling of pain. It is also sometimes reported as the maximal claudication symptom. So you would just want to document, if you're doing this for initial claudication symptoms, and let's say they get there at 4 minutes, a graded treadmill test, 4 minutes to initial claudication symptom. Or if you're going to maximum, then you document that. Graded treadmill test, 8 minutes to maximal claudication symptom, where they just couldn't take it anymore. So you measure the time to pain and their maximal walking time. Another assessment of peripheral arterial disease is the ankle brachial index, abbreviated ABI, ankle brachial index. The ankle brachial index is a ratio of the systolic pressure at the ankle compared to the systolic pressure at the brachial artery. For the ankle systolic pressure, it is appropriate to take this in either dorsalis pedis or the posterior tib artery. That's what the DP and the PT stand for on this picture. Now, in a normal, healthy individual, your pressure should really be just about the same, whether it's in your arm or your leg. If anything, maybe a little higher in your lower extremity because of the effect of gravity. But in general, they should be about the same. If there is atherosclerosis blocking blood flow to the lower extremity, that will reduce the downstream systolic pressure. So as you can see here, and you don't have to memorize normal, but 0.9 to 1.3 is considered normal. Kind of in that range where they're pretty close and maybe the ankle's a little higher. When you get to less than 0.9, you have significant peripheral arterial disease. There's a difference, a significant enough difference between these two pressures to illustrate that you have blockage of your artery. When it is less than 0.41, that is severe peripheral arterial disease. Another assessment that can be used is using a pain rating scale for the claudication pain. So just giving a number to their pain when they're walking. Again, this can be used to track change over time and kind of create some objectivity to their subjective report of pain. So I rarely give the nitty-gritty details of exercise prescriptions in the notes, But for whatever reason, historically, the board exam loves progressive conditioning programs. So I would become really familiar with this process. So we just went through all the ways that we evaluate it. Now let's talk about how we actually treat peripheral arterial disease with exercise. Okay, so this is what we can actually do about a disease. This is very exciting for pathophys because very often we don't get to make this big of an impact, but here we can. Okay, so you can use exercise to treat peripheral arterial disease by putting patients through a progressive conditioning program. So let's look at what it is. What you want to do is you want to put them on a treadmill and set the speed and grade of the treadmill so that they have claudication pain within 3 to 5 minutes. That kind of gives you the gauge for the intensity. And the pain you should be experiencing is level 1 pain. So just minimal discomfort in 3 to 5 minutes. Then you have the patient walk until the pain is moderate, so reaches level 2. And then they rest until the pain is resolved. Now, this is still the documented protocol, but as you see in your notes, I have a little subheading there that I wanted to put it on your radar, that the newest studies that are coming out are showing that the best results of this exercise program are achieved if at this stage, instead of going to moderate, you have them walk to near maximal pain. So the Goodman-Fuller text is one of the main pathology books that guides kind of PT practice. And in the Goodman-Fuller book, they are really pushing towards moving this protocol to a near maximal pain. The AHA guide, as it says in the bottom, is still publishing this as pain to moderate. So this is kind of where the evidence of this, the evidence for this program is kind of getting ahead of the published protocol. So I think over your time in PT practice in the next couple of years, this will most likely be shifting into severe pain. Okay, so you have the patient walk to moderate or severe pain. You have them rest until the pain is resolved, and then you do it again. You resume walking again until that moderate to severe claudication pain is induced, and you rest. And you repeat these exercise rest cycles for 35 minutes. The goal is to, kind of as soon as you can, progress them longer and longer to get to 50 minutes per session. And you want to do this for 12 weeks, 3 to 5 times a week for 12 weeks. So, what are we doing here? Why are we doing this to our patients? This sounds awful, like make them walk into pain and then rest. What are we doing every time they're having that moderate to severe pain? What's happening in their tissue? We're creating ischemia, right? We're creating an ischemic environment. Do you know how the body responds to ischemia? If it's repeatedly experiencing reduced blood flow, is there anything the body could do to make it better? A repeated stimulus, challenging a tissue to the point of ischemia repeatedly over time, what could that tissue do to fix this problem? It could grow new blood vessels, a process known as angiogenesis. Angiogenesis is the growth of new blood vessels. Ischemia will stimulate the cellular changes needed to form collateral vessel growth. This is amazing. We can actually make patients or help patients grow new blood vessels and create new routes of blood flow delivery, collateral vessels. This is an actual treatment for peripheral arterial disease, because if you start budding new branches, you will have better oxygen delivery. Even if some of the vessels are still clogged, this doesn't take away the plaque. It is a stimulus for new vessel growth. The same phenomenon of repeated ischemia causing vascular budding and collateral vessel growth and angiogenesis actually does occur in the heart as well. The patients who have long-standing angina and then end up having a myocardial infarction typically do better than patients who, let's say, get a heart attack from an embolus or have never had a symptom before and then boom, they get a massive heart attack, because the patients who had angina for months or years have much better collateral vessel growth. That ischemic tissue stimulated the vessel growth. The top of the next page is a really important concept. If somebody has signs of peripheral arterial disease, they have atherosclerosis, right? And if you think about the processes by which a patient gets atherosclerosis, it's not local. It's not in only one area, right? If you are a smoker and you have increased oxidative stress in your blood, you have it everywhere. If you have diabetes and you have high blood glucose damaging endothelial cells, you have that damage everywhere. If you have a lot of inflammatory cytokines due to obesity or lack of physical activity, that's going to damage endothelial cells everywhere. So if you have vascular disease anywhere in your body, it is likely, very likely, that you have some degree of vascular disease all over your body. So somebody who has intermittent claudication, right, leg pain with walking, and they have no heart signs at all, no angina, no problem with their heart. If they have atherosclerosis so bad that they're experiencing peripheral arterial disease, they have atherosclerosis in their heart. They just haven't yet blocked it enough to get symptoms. So for that reason, anyone with peripheral arterial disease, you want to be both watching for the signs of coronary artery disease, very vigilant for any evidence of ischemia, but also taking vitals on these patients at rest, during exercise, and during recovery. Because it is very possible, especially if they have been relatively inactive and now they're coming to you and you're inducing exercise, that you might uncover the first signs of cardiac ischemia. So if you have atherosclerosis anywhere, you have atherosclerosis everywhere. It's just a matter of to what degree. So take it as a kind of gift that you're given this morning, and take it very seriously and be vigilant for evidence that they are beginning to have cardiac symptoms. The next one on the list is vasculitis. And when itis is at the end of the word, it tells you that you're talking about something with inflammation. So vasculitis should tell you that you're talking about inflammation of a blood vessel. So as it says in your notes, this is actually a very big umbrella term for a group of vascular disorders that all end up causing inflammatory injury and eventually necrotic cell death to the blood vessel wall. So there are many different disorders that fall under this, but I'm going to keep it a little bit zoomed out. If you get a specific diagnosis and you look up the diagnosis and it tells you it is a vasculitis, then you can apply the concepts from this lecture to the individual diagnosis as opposed to memorizing a laundry list of a bunch of vascular names. This is a graph that kind of shows, again, we're not going to memorize these names, but some of the most common types of vasculitis, like Kawasaki's disease is on here. Some of you guys might have heard of that one. Giant cell arteritis, we're actually going to talk about that one a little bit specifically. But this would be, you get a patient with a diagnosis and you're like, what in the heck is this? You look it up before you begin your evaluation, hopefully, and you see, oh, I'm dealing with a vasculitis. I'm dealing with a disease that must be causing an inflammation of their blood vessels. So the two most common causes, the first is an autoimmune disease, where their own immune system is attacking the blood vessel wall and causing the inflammation. So in your notes, I mentioned that it's very common for patients who have rheumatoid arthritis, very common for patients who have lupus to develop a vasculitis, because their immune system is already kind of primed and ramped up to attack itself, that it can end up attacking the blood vessels. The second most common cause of vasculitis is an infection. So the vascular wall gets invaded by an infectious pathogen. But either way, whether it's your own body attacking the blood vessels or an infection, it causes an inflammation. So the clinical evidence of vasculitis, the first four on the list, and yours are listed in one line instead of a bullet point, are what's referred to as constitutional symptoms. The expression constitutional symptoms is a group of symptoms that can affect many different symptoms of the body. They are kind of common symptoms when something is going wrong in the body. Group of symptoms that often come together that tell you something systemic is going wrong in the body. Fever, muscle pain, joint pain, malaise, constitutional symptoms. So because vasculitis is related to the immune system, that's why this vascular disease has evidence that kind of goes with your immune system being ramped up. Fever, muscle and joint pain. Malaise, again, is that general feeling of being unwell. That's that sense where you know the cold is coming, but you have no symptoms yet. It's kind of malaise. So this makes this condition very different than, let's say, atherosclerosis, right? Atherosclerosis, you don't have joint pain or muscle pain. You have no idea it's there. All the symptoms of atherosclerosis are related to the effect of reduced blood delivery. Whereas here, we actually have evidence that the body is fighting something. You have these constitutional symptoms. In addition to the constitutional symptoms, you will have the symptoms of ischemia. So at this point, the evidence of the vasculitis is completely dependent on which vascular bed is affected by the inflammation. It's common to see skin and rashes and ulcers, ulcerations of the skin, where the vascular bed was affected by the inflammation. The kidney is particularly vulnerable, that if there's inflammation in the vessels going to the kidney, it can cause dysfunction. They can experience neuropathies, right? The lack of blood flow to the nerve can give the nerve symptoms. If you get inflammation of the vessels in the bowel, you can get a bowel infarction. They can all go with vasculitis. A person that is experiencing vasculitis is having an inflammation. So the treatment should kind of match that. The people who are having immune-mediated causes, autoimmune disease, will go on an autoimmune suppressive drug. And again, this can get a little tricky for the medical team because they need to determine the cause. If the person is actually experiencing vasculitis because of an infection, an immune suppressive drug will limit their ability to fight the infection. So there's a decision to be made here. But if it's an autoimmune cause, this would be an effective way of suppressing your body attacking the blood vessel. Both causes of the vasculitis could respond from steroids. Steroids can help reduce inflammation in both causes. Now, we will talk about this a lot because many of the patients coming up in other pathologies are on long-term steroids. But chronic use of steroids reduces your bone mineral density. And in the bone lecture, we'll actually talk about the mechanism, but just start to think through that when someone is on steroids, for a long time, you are going to be worried about their bones, thinking about whether or not they might have osteoporosis, the strength of the steroids, in addition to how long they were on them, makes the bones more and more susceptible. Avascular necrosis is death of bone due to lack of blood supply. So because the vasculitis can reduce the blood, they can end up actually damaging the bones. Now, the most common of all the vasculitises that are out there is temporal arteritis, or sometimes called giant cell arteritis. It affects mainly the arteries of the head, especially the temporal artery, but it also can be the vertebral and the ophthalmic. Things to be aware of, because this is more common, and because it involves the arteries of the head, this can actually affect vision and can lead to permanent vision loss if not treated very quickly. So I just want this one to really be on your radar. Temporal arteritis would have those constitutional symptoms, right? Evidence that the body's kind of fighting something. And then typically very sudden, severe throbbing headache can radiate down their face and neck. They often have visual disturbances and blindness and some jaw pain, like a claudication jaw pain. Most often you see the first two, the sudden throbbing headache and the radiation down the side of your face. This responds to treatment. So patients are typically on steroids for somewhere between 6 to 12 months. But if there's no treatment, this can lead to permanent vision loss. So if somebody presents with these symptoms, you want to react quickly and get them to medical attention so they can start steroids. And by respond quickly, I'm not referring to calling 911, but having them go see a provider, within that day, like go to an urgent care or get in to see their provider. All right, we're at a good break point here in terms of time. So we got through our first two. Starting next week when we are in person, we will talk about Raynaud's syndrome. All right, have a great rest of your time. If you're just finishing this on Friday, don't forget I have in-person office hours in 356 at noon. Bye.